Wonderful. Hello, everybody. This is 5 p.m. We are going to start the fireside chat. My name is Chuza Moon, and I am the Associate Professor at the College of Nursing at University of Iowa. As a member of Education Committee at the National Center for Gerontological Nursing Excellence, I'm very honored to have our third NHCGNE Fireside Chat. This is a free monthly series brought to you by the Education Committee. These sessions um, will feature distinguished educators in gerontologic nursing and other experts sharing insights on key topics in gerontological nursing. Each chat begins with a brief presentation followed by an informal discussion where you can engage directly with the speakers. Today we have Dr. Florence Mandevou, who will be talking about the concept analysis and implications for geriatric nursing education. Dr. Florence Mandevou is an accomplished nurse educator, a clinical nurse specialist, and a leader with a strong background in gerontological nursing. She is an assistant professor at Upstate Medical University's College of Nursing in Syracuse, New York. She served as a DNP program director from 2021 to 2023 with a Doctor of Nursing Practice degree from Upstate Medical University and over a decade of experience in nursing and leadership. Dr. Mandevou is dedicated to advancing nursing practice through education, research, and mentorship. Her expertise spans multiple facets of healthcare, including gerontological care, palliative care, in acute and long-term settings. She has taught courses in advanced health assessment, family nursing theory, clinical pathophysiology, palliative care, and so on. She also published an article in a peer-reviewed journal about the 3Ds, which are delirium, dementia, and depression. And newly acquired cognitive impairment issues for the ICU nurses. She worked on multiple projects to improve care for older adults, especially the implementation of the delirium screening and management on the med-surg floors, reducing the use of antipsychotic medications for people with dementia, increasing use of non-pharmacological interventions to manage psychological symptoms of dementia, coordinating the niche coordinator for two different organizations, and telephone follow-up for transitional care from hospital to home for geriatric patients. Additionally, she is an active member of professional and community organizations, demonstrating her commitment to service and advocacy in nursing. She received multiple awards, including the National Hartford Center for Gerontological Nursing Excellence Award and Carter and T. Franklin William Geriatric Award from the Rochester Academy of Medicine and the John Bernard Henry MD Endowed Scholarship Award. Her leadership in education and clinical practice continues to shape the future of nursing, inspiring the next generation of healthcare professionals. In the next 15 minutes, Dr. Mandevou will talk about the concept analysis.
Thank you. I can take it from here now.
Yes.
Thank you so much for allowing me to come and present at the fireside chat. Uncertainty is a concept I decided to look at with a perspective of gerontological nursing care in the summer of 2024. And what I found there was quite intriguing, and I decided maybe I should share the fireside chat, the findings. So really, uncertainty is tied to complexity of care or whatever other things they are. But given that gerontological nursing care can be complex and would require nurses to be competent in their skills for that specialized care of the older adults, it was important for me to look at uncertainty and how it is handled by nurses. Multimorbidity is one of the most complex issue we deal with in gerontology, and it tends to bring up uncertainty in so many ways and so many levels for the nurse and other practicing clinicians, as well as nurse educators. And we know that uncertainty can hinder decision making. So this is why I said this is too important to not look into, because decision making and uncertainty is a problem if uncertainty is not managed properly. And this was also a personal interest of mine to do this concept analysis. As we all know, uncertainty is everywhere in healthcare, even in general life. So healthcare has many levels of uncertainty that could stem from the clinical care itself, the clinician or the nurse at the bedside, or the patient and their families experiencing all kinds of uncertainties. But in regular life, we know there are uncertainties as well. And uncertainty can be experienced on an individual level or on a population level. So if anything else, COVID taught us that we all experience uncertainty on a population level. So healthcare is now more complex than ever before. We know there's a lot of developments that happen and technology improving and treatments improving. At the same time, people are living longer. And that also presents a lot of challenging issues that would cause complexity. The aging population, which is growing, and the people coming in with multimorbidity, it means there will be some complex and challenging issues to work with, but those issues present uncertainty in clinical decision making. You could look at it from any angle of gerontological care. You would find multimorbidity is not the only thing, but palliative care decisions as well could be complex. At the bedside, even just one thing such as delirium superimposed on dementia could present complexity for the nurse, especially if they have not been trained in managing care of older adults. So uncertainty in itself is not bad, but what can be problematic is uncertainty intolerance, which is the one that is associated with impaired clinical decision making and clinical judgment. Uncertainty intolerance is also associated with mental distress for the healthcare worker and the resultant burnout. And what I found as I was looking in the literature was that there is nothing that was showing me that nurses are being trained to recognize and manage uncertainty during their education or training to prepare them for practice. So I felt like, okay, there they are, they've finished their education and we've trained them well to take care of patients. But the uncertainty that always comes with healthcare, we don't quite spend time in that, and to say they will experience uncertainty and they would need to be able to manage that uncertainty when it happens, and let alone recognize it. So I used the Walker and Avant 8-step concept analysis method. And of the 8 steps, I am going to only focus on a model case and not all the other cases. So in the work we do, all of the people in geriatrics, we know complexity can result from any of those areas I am showing here. But multimorbidity is the biggest one. And of course, with multimorbidity, those conditions need medications to manage, and the slippery slope could be leading to polypharmacy. And we know that there's also geriatric syndromes that older adults experience. But then another complexity comes when there's acute on chronic disease. And these are patients that may have pain that's chronic, and then they have acute pain as well on top of that. Or they may have dementia, that's chronic confusion, and then they would have delirium. which we call delirium superimposed on dementia. That's another complexity especially for the nurses not trained in the management of geriatric care. And then our older adults, they also have vague symptoms and also a typical presentation of illness, which we learned about in the last fireside chat. The one before the last one. So the typical presentation of illness is not something that we emphasize, and yet we know that nurses are coming in and taking care of more older adults than they've ever done before. So the focus is mostly on the general presentation of illness, and therefore we find that it becomes quite complex for the untrained nurse who lacks geriatric competencies to recognize a typical presentation or vague symptoms that they mean something for the older adult. Age-related changes, those happen, but when you have pathologic changes mixed up with age-related changes, that also present another complexity. And that's with older adults. And that's where complexity comes from. And complexity is one of the precursors of uncertainty, as you shall see. There's different sub-competencies of uncertainty. And I have listed some of the main ones I found in literature. So there is uncertainty orientation, uncertainty tolerance, which is what we want. When there's uncertainty, we want nurses to tolerate that and manage it. And also we want them to be able to reduce it. But to be able to do that, to reduce uncertainty, they ought to have the skills to do that. What we don't want is what I highlighted in red, which is uncertainty intolerance. And that provokes all the other symptoms I mentioned, like mental distress for the nurse. The other thing we don't want is avoidance, because it will also lead to nurses tuning out and not wanting to learn more. So with uncertainty orientation, those are the nurses that when they experience uncertainty, they are going to dig deeper and look for information. And usually uncertainty happens when you don't have enough knowledge, enough information, or there's complexity, and you can't find information to help yourself to make a decision. So the aim of the concept analysis was to identify and define the types and attributes of the concept of uncertainty in relation to gerontological nursing education. Because I included education here because that's where it should begin during nurse training, to be able to identify that uncertainty is a problem, but preparing for how to reduce it or identify it is what we should focus on. The other thing was to determine the usefulness of this concept in nursing practice. There were several definitions in literature. Some of the definitions were basic definitions. For example, in the dictionary definitions, uncertainty was defined as the quality or state of being uncertain. So I said to myself, okay, they're using the same word uncertain. I need more. I need it to be deeper. So that quality of state and being, that's uncertainty being used in general terms as a regular term, or being in doubt or a feeling or attitude that one does not know the truth. So those were dictionary definitions, as you can tell. But then as I dug deeper in the literature, I found definitions that were more explaining more. Uncertainty as the conscious metacognitive awareness of ignorance that came from Hegel et al. Or it is the cognitive state created when a person cannot adequately structure or categorize an event because of the lack of sufficient cues. And we'll talk about cues in the nursing frameworks that we use. And practice uncertainty, which was distinguished from the regular uncertainty, happens when healthcare providers feel uncomfortable in response to unfamiliar or challenging patient situations. That was another definition given. So the uses of the concept, this concept was used in so many areas, on so many disciplines. And the uncertainty concept can be found in physics, mathematics, statistics, engineering, and so forth. But the one that kind of lined up with what I was looking for is used in the communication discipline and in terms of reducing uncertainty when people meet for the first time. And also the one that was used is uncertainty tolerance that is used in education among healthcare professionals. And mostly it was found in the discipline of medicine. That's where there was an abundance of literature talking about uncertainty intolerance among med students as well as among providers already in practice. And this is also used in patients with family patients and family to help them understand and cope with illness. And this was done in the nursing field, and it's widely used. And I know that nurses should know this theory as it pertains to patients and families, so they can help them as they are trying to cope with illness. But understanding how nurses experience uncertainty during decision making was more important as I was looking at this theory, but I did not find a whole lot. There were a few studies done, and one by Cranley et al. In 2009 looked at that. It was a qualitative study. And there's more studies that are coming up now. And then understanding the nurse's response to anxiety with transition to practice was one that happened during the pandemic as they were waiting to take their licensing exam. They experienced some uncertainty right there. And then it is also used by psychiatrists to diagnose anxiety in people who are always experiencing uncertainty and getting anxious from that. So it can be used in the realm of diagnosing. So as I have just gone over the different kinds of uncertainty, you can see that uncertainty is quite broad, and we have to look at the different facets. Now, for the defining attributes, what I found was probability and temporality and perception kept showing up in the literature. And for the probability, that was the likelihood of something not desirable happening, and that would start to contribute to uncertainty, the feeling of uncertainty. And also probability of the nurse making a clinical decision that is in error, that also led to uncertainty. Then temporality was not knowing what the future holds. As they're making a decision, they don't quite know when the situation that they are looking at, the uncertain situation, when it will be over or what will happen next. So the future is not just the far future, it could be the next 10 minutes, what's going to happen with the patient. Not knowing how long it will take before an uncertain situation is resolved. Is this going to be over and be solved? Also the fear of the unknown. And then perception, uncertainty does not happen unless the individualness has perceived in the situation and appraise it as a threat. Unless they do that, the uncertainty does not quite arise. It's the threat part of it that is perceived, as well as when they perceive that they don't have enough knowledge or they don't have skills or the competencies that they need to make a decision. And also what could happen, the potential outcomes. They know something could go wrong. So that perception is always tied to uncertainty. So for the model case, I actually thought rather than talk about the nurse and how they are responding to the situation at that time, I should also give the complexity of the nature. So this is a nurse floor who is a nurse on a typical med-surg unit. She is assigned to care for 4 patients in her shift, but one of her patients is an older adult, 95 years old, and came in with what would appear like 2 things going on, a UTI and the right hip fracture. So for the nurse who's not competent in gerontological care, they might look at just those 2 things. So the patient also had other things going on, and the nurse floor was kind of seeing a worsening confusion, but because the patient has dementia, nurse floor could just attribute that to dementia, but it was worsening. But the patient also had chronic back pain, COPD, end-stage dementia, and was also hard of hearing. And we know sensory issues are big in older adults. And on a med-surg unit, a lot is going on. So for this patient to start to decline, some of the decline was so subtle. So nurse floor continues to check on the patient, but she's uncertain of what was going on. And that uncertainty starts to wake up on her. So she does vital signs and everything looks stable, her assessment. But then what is within defined limits to an untrained nurse in gerontology, they would look at the regular vital signs and think nothing is going on. For example, the temperature might look like it's okay, but that's an atypical presentation sometimes when the temperature does not show, but the patient is more confused. So the confusion is what might be a big symptom versus the temperature being shown on the vital signs. So the nurse was okay because the patient was not pulling out things and was just restless, was not trying to get out of bed, was not complaining of pain. But pain is something that we know in patients with dementia, that it is difficult for nurses to assess. There is uncertainty right there that's documented in the literature as it relates to pain in patients with dementia. So given that she has a hip fracture, she has chronic pain, there's likely going to be pain there, that the nurse who is not trained in managing pain in dementia, who has no gerontological background to tease all these things out, would definitely miss it. So the model case would be somebody with no gerontology experience and how they would approach this. I think at the end, when we have time, we'll discuss what we see, what we might see a nurse without training in gerontology doing versus a nurse who is trained in gerontology.
Dr. Mandeville, our fireside chat is scheduled for 30 minutes, so we have, can you wrap it up in 2 minutes for your presentation so that the audience can ask you questions? Would that be okay?
Yes, thank you. So uncertainty can be measured, and those are the empirical reference. I've listed several tools there. So if we can measure it, we can then know if it's decreasing or not. And those are the antecedents: probability, complexity, ambiguity. They have to be there in order for uncertainty to happen, and also fear of the unknown. And those are the consequences. The consequences can be emotional, behavioral, as well as cognitive. And what's listed on the side are the examples. So the consequences happen in those 3 domains. And these are the result of uncertainty intolerance. Anxiety is one of those things, burnout, impaired decision-making, etc. So we need gerontological nursing competencies in order to bridge that gap in what we already know in terms of our nursing process or the clinical judgment measurement model. We need to embed the gerontological competencies in there. So the assessment is not just the regular assessment, but specific to the older adult. All right. So I will go ahead and take questions.
This is wonderful. Just wanted to comment that how wonderful it is. And then thank you for providing the case study and also the key takeaways and applications and how relevant it is for the nursing NHCGNE competencies. Any questions? I do have a question, just quick question that you mentioned about the negative consequences about the uncertainties. And would that be applying to the patients or nurses?
There are consequences to both.
Mm-hmm.
If I could go back to that slide. For the nurses, there's increase in anxiety and burnout. It has been noticed, it has been seen in that, and impaired decision making. The impaired decision making is what will impact the patient because there'll be poor clinical judgment, and then there's compromised patient safety, as well as delayed care and poor patient outcomes ultimately. And for the nurse well-being, the other thing that is noticed in that is mentioned in the literature is poor job satisfaction, and as well as nurse well-being overall. I know we talk about burnout a lot, but some of the burnout may be stemming from the intolerance of uncertainty when dealing with complexity.
Yes, so like covering like why uncertainty rise and the consequences of the uncertainty was very helpful, and I can see applications for uh, clinicians, not just for nurses, but also in clinicians in general, and also for patients and family members. Any
Yes.
questions?
That was a wonderful presentation. Do you have any statistics about what is being taught in academia? You know, when I went to school, there was a whole course on gerontological nursing. And, you know, now it's usually threaded through the curriculum. But do you have any stats on that?
No, I didn't have stats, but what I know is there's variability in the approach as well as in how much the content is put in there. When it's threaded in, we don't know if some things are lost. And I think from watching what happens in healthcare, there is studies saying they're coming unprepared to practice fully. There's that evidence. And part of that has to do also with the preparation for managing gerontological patients.
I was thinking it would be nice if there was some type of preceptorship for people that are going to be taking care of this patient population that maybe could alleviate some of this uncertainty when they go into that type of practice.
Yes. Yes, and I would just say with the older population increasing, we also see more older adults patients. It's like on a typical med-surg unit, you might have more older adult patients than the younger patients.
Awesome. I see from the chat box that the comments are very positive, Dr. Mendevue. A first year PhD student saying that the concept analysis very helpful, and this is very useful discussion about covering this gerontological competencies, and above and beyond excellent presentation that you gave us. This was very helpful. I want to thank Dr. Mendevue for providing this wonderful presentation. I hope it helped everyone to shape their understandings in uncertainties although things are uncertain in everyday life. And I want to introduce our next webinar series, the February Mentoring Panel hosted by the NHGNE. It will be on Wednesday, February 26th from 1 to 2 p.m. on Eastern Time. So we haven't decided what topics to cover for next month's fireside chat, but in between, I hope you can enjoy the mentoring committee as well. And if you have any questions, please email me or Dr. Mandaboo for any content related to uncertainty and concept analysis or gerontological nursing education.
Yes, I'd love to talk more about that. And I have a list of references at the end of the presentation, and there's more in the literature. And just as I was preparing to do this, I realized there's more recent studies. I didn't have time to dig through to bring it to the discussion, but
Yes.
there's studies
Sure.
from this year.
We need
From
more.
this year.
Yes, wonderful. I hope everyone have a very, very wonderful night. And I hope to hear more about Dr. Mandaboo's research, concept analysis, and practice applications around this area. And I hope to see everyone in the next month's fireside chat.
Yes, thank you.
Thank you.